Good evening, and thank you for joining us. My name is Dr. Joan Reed. I'm Dean for Diversity and Community Partnership at Harvard Medical School. And thank you again for joining us for our discussion on heart health, where we are joined by physicians, faculty, students, trainees, social workers, and administrators from multiple schools and community organizations. Today's webinar is sponsored by the Harvard Medical School Office for Diversity, Inclusion, and Community Partnership, DICP. The mission of DICP is to advance diversity and inclusion in health, biomedical, behavioral, and STEM fields in ways that build individual and institutional capacity to achieve excellence, foster innovation, and ensure equity in health locally, nationally, and globally. DICP efforts support the career development of junior faculty, trainees, and students, identifies and trains leaders in academic medicine and health policy, and provides programs that address crucial pipeline issues. Today's webinar, Heart Health, is offered through our DICP Equity and Social Justice Initiative. It is the 7th ESJ webinar in the current academic year. A history about the program: in the fall of 2016, a planning committee comprised of faculty, staff, and students representing our full HMS community discussed the establishment of equity and social justice in a series to address health disparities, social determinants of health, leadership in health systems, health policy, and other areas affecting vulnerable populations. In 2016, an average of 10 to 25 programs since 2016, an average of 10 to 12 programs have been provided annually and in collaboration with other HMS-affiliated institutions. ESJ events focus on 4 areas: history and context, culture and environment, health disparities, and leadership and skills development. This year, the ESJ lecture series has tackled health issues that often impact disadvantaged and vulnerable populations. Our conversations and speakers have addressed not just defining the disparity, but also discuss interventions on a community, hospital, and policy level in order to address inequities. Dr. Alden Landry, who coordinates our office's ESJ discussions, will share more on this in a moment. But a few housekeeping notes before we begin today's session. The chat is not available. Microphones will be muted. You can use the Q&A at the bottom of your screen to post questions to panelists, and the webinar is being recorded and will be posted on our DICP website in a few days. Now, it's my pleasure to introduce Dr. Alden Landry. Dr. Landry is an emergency medicine physician at Beth Israel Deaconess Medical Center and is the founder of Motivating Pathways, Inc. He is assistant professor of emergency medicine at Harvard Medical School and assistant dean in the Office for Diversity, Inclusion, and Community Partnership at Harvard Medical School. And now I'd like to turn the program over to Dr. Landry.
Thank you, Dr. Reed, for that introduction. And thank you to everyone joining us for our Equity and Social Justice lecture series on heart health. I'm excited about this discussion that we're going to have over the course of the next hour or so. We have some amazing speakers who are joining us this afternoon to have this conversation and for us to think more critically about health equity when it comes to heart health. As Dr. Reed mentioned, the Equity and Social Justice lecture series is addressing a number of issues related to disparities and inequities, specifically looking at how we can improve care for our vulnerable populations. Obviously, with it being Heart Month for the US, we're going to have this conversation around heart health. The goal of this conversation is to really focus on the disparities that exist within cardiology, and more importantly, to discuss the interventions that are needed to improve care for all. As Dr. Reed mentioned, this is going to be a panel discussion, so we have some amazing panelists who are joining us who I'll introduce. We'll have our discussion, and we'll definitely be sure to keep the conversation going in the Q&A. So if you have questions for our presenters, be sure to reach out to us through there, and I'll try and peruse some of the questions from our audience from the Q&A session to bring that into our conversation. With that, I want to go ahead and introduce our speakers for this afternoon. First, I want to introduce Dr. Michelle Johnson. She's the Vice Chair of Health Equity in the Department of Medicine and a Clinical Director of Cardiology at Memorial Sloan-Kettering Cancer Center. She is an attending physician at the Memorial Hospital for Cancer and Allied Diseases in New York. Next is Dr. Keila Lopez, who is a newly minted associate professor with tenure of pediatrics, congratulations, in the section of pediatric cardiology at Texas Children's Hospital and Baylor College of Medicine. We also have Dr. Angelica Motta, who is an associate professor at the Burrell Osteopathic School of Medicine and an attending for the internal medicine residency program at MountainView Regional Medical Center in Las Cruces, New Mexico. And finally, we have Dr. Quentin Youmans, who is a chief fellow in the Division of Cardiology at Northwestern University Feinberg School of Medicine. With that, I want to ask my first round of questions to you, Dr. Motta. So as we are having this conversation around heart health, we think about the disparities that exist within different patient populations. Can you discuss the issues that you are seeing specifically in respect to the cultural and linguistic, making sure that care is appropriate from a linguistic and culturally appropriate standpoint, particularly in the patient populations that you're serving?
Yes, thank you for having me, Dr. Landry. This is a great audience, and I hope that we can all learn from each other. But the biggest thing that we see is a lot of the times there's cultural discrepancies between different cultures. A lot of the times when I seen it between my partners, that if they're different cultures, like if they're white versus Hispanic population, they tend to assess patients differently. I have had experience where, they disregard, because as Hispanics, we do tend to be a little bit more, I don't know if I could say dramatic, but, they tend to label us more as, an anxiety attack versus truly heart disease. So it goes under evaluated, and I've seen it where, one of my partners, they labeled the patient, oh, she's having an anxiety attack, and she was actually having a heart attack. And mainly it's because she was very overly expressive and very sensitive, and she was crying, and so that's one area. Also, a lot of times that they translate is lost in translation, especially if they don't speak English as their first language, and they're not able to communicate with the patient. They have that barrier, and they're not able to explicitly tell the doctor, and vice versa. They're not able to communicate with each other what they're trying to do, and they might actually reject to do certain procedures or the stress test just because it wasn't explained appropriately, or they couldn't understand it, and they use a translator, and a lot of times with the translators, they're not able to fully express what we're trying to do. So those are the major areas that I seen that we have trouble between the cultures and between the different languages. There are significant barriers on treating certain populations.
Forgive me. When you mentioned that we have issues specifically related to how patients are demonstrative in expressing their care. We have some patients that are stoic, some that are that tend to be very outgoing and letting us know as providers whether there's an issue that's going on. We often try and gauge that based off of who we are as individuals and what we're used to in our own experiences. And so what one person may see as dramatic is another person's appropriate response to a life-threatening condition. And I think we have to be aware of how we treat people differently based on our own personal biases and how that comes into play clinically. And you brought up a number of issues specifically related to interpreters, and we can talk about that at a later point. I think context matters and language matters, and how we express pain and how that is communicated with either relation to an acute condition or how that's going to be managed. Is something that we can dive into a little bit further. But I want to switch topics a little bit. And so we talk about disparities that happen because of race, ethnicity, socioeconomic status. But there's also disparities that happen because of gender identity. And can you talk about how those issues may play out clinically and when you're taking care of women who come into your clinic or into your cath lab or into the emergency department? and how sometimes women are treated differently than men when it comes to heart disease?
So they actually have done studies, how they have many women are, first they are unaware they have coronary heart disease, it's the #1 killer. The biggest concern to them is more actually breast cancer or dying from that than actually heart disease. So there's also a lack of awareness, I think, sometimes among even the primary care physicians or other healthcare providers. And we've seen a later presentation of women in comparison to men. So we tend to see more like the older, like I think 10 years in comparison to men, that they present a lot much younger seeking healthcare in comparison to women. The other thing is, again, because when we see and evaluate the patients, I seen where, a lot of the different diagnoses have been labeled as anxiety, and, they end up being that they have presbyopia angina, or they actually do have heart disease. And it's just in the presentation of how these women present either to the primary care, to healthcare, to cardiologists, or even in the emergency department. And they don't give them the same, medical treatment as, if somebody presents with chest pain and they're labeled acute coronary syndrome, they're going to give them that protocol versus somebody that they see women and they tend to be more, okay, this is more of an anxiety attack. So they're discharged. They're not telling them, go follow up a cardiologist. And they just tell her, you know what, you need your anxiety control. And we do have underdiagnosis of, different arrhythmias, different heart disease. And mainly and that we see it more in women. As far as treatment and as far as assessment and evaluation of women, we tend to not see and treat, and we undertreat women and when they present with similar symptoms as men in different scenarios, not only even on the primary care, but even in the ER, we see it as well.
Yeah, and I distinctly remember I was early in my medical education when the Shulman Study that came out in the New England Journal of Medicine in 1999, and it looked at the management of unstable angina. And one of the things I remember distinctly about the study, not to get into too much to the study or what it showed, but I just remember being in medical school, and the thinking was, oh, women present differently, so you have to do X, Y, and Z when you're taking care of a woman who's coming in with shortness of breath and chest pain, which completely missed the whole purpose of the study, in so much that we just weren't paying attention to the women who were presenting to healthcare settings with classic symptoms for heart disease. And so I think it's just, again, it goes back to the differences on how we approach a history that we take, and truly believing our patients, and ultimately doing the right workup for our patients when they're in front of us and they're telling us all the right things. I do want to just change subjects one more time and talk about the issue specifically related to workforce diversity and equity. And as we work towards equity, what role does diversity play, particularly when it comes to caring for patients, and how do we make sure that we address the issues related to the Latinx cardiology workforce?
So that's a great question, and and it's a great point. That's I think, as a lot of people know, I mean, the Hispanic, or actually minorities itself, are very underrepresented in cardiology. Women are underrepresented. I think we're only 10% of all cardiologists are women, and then Hispanic women, it's only 5% in cardiology. So we're really not getting that much diverse group, and even other minorities the same way. But I think we just have to have more mentors willing to talk to all the future generations, medical students, residents, and trying to get them interested in cardiology. We need more women cardiologists. I know that they just did a study that they tend to be better surgeons, but it's not only that, it's just that I think we listen, and I think trying to broaden that and make it more a diverse group, and trying to let the future generations that you don't necessarily have to. One of my actually attendings told me that you have to marry cardiology, which is wrong. But that's a lot of the times how they train you. They say, if you're going to be a cardiologist, just make sure you understand that you're going to be married to cardiology. You're not going to have a life outside this. And so you're pushing away potential candidates to cardiology, or even interventional cardiology, structural cardiology, away, just because, we want to have a family. And then as a woman, they tell you, well, you're not going to have a life. And I think that's wrong. I think we just need to have more mentors, women mentors in cardiology, so that, and the same thing with minorities, so that we can push the next generations to try and continue and try to bring them into this area, which, it's very broad, and you can do a lot of different things. It doesn't necessarily have to be general cardiology. You can do imaging, you can do a structural, interventional, peripheral. So it's a fascinating area, but we just have to have a lot of strong mentors to be able to support that. Because again, if you don't have that, and even in my fellowship, we didn't have female attendings. I think I had one. And, getting pregnant, it was kind of during that fellowship, they didn't look at it like, oh, I'm going to be very supportive. They were not. You're weak, you're getting pregnant during fellowship. How dare you? So you have to have a community that helps you and builds you up and brings in a diverse group, because otherwise, then, there's still going to be people that are going to be pushing minority women away.
100% agree. Thank you for sharing that, and then talking about your own training experience. I think for a lot of us, we wouldn't be in the positions we are in now if it wasn't for strong mentorship and people supporting us. And we, of course, always have people who are going to serve as barriers as we try and pursue our goals. And they may be, well, they think they may be well-intentioned as they make a comment like, oh, you have to be married to a specialty in order to pursue it. But in actuality, they can be really discouraging for individuals as they try and pursue their careers in medicine. So thank you, Dr. Motta, for joining us. I want to turn to you, Dr. Youmans. Continue on this discussion. As you think about your journey into cardiology, what issues do you think are impacting diversity, and how can we encourage more underrepresented in medicine individuals to pursue a career in cardiology?
Absolutely. Thanks so much, Dr. Landry, and I'm so happy to be here to chat with you all. When I think about addressing disparities in any field, but in particular in cardiology, I think, diversifying the workforce is really a critical step that must take place in order for us to address these disparities. I think there are kind of individual level factors, and then there are more systemic factors that might perpetuate the dearth of diversity within cardiology. When I think back about my own experience kind of going through training, I knew that I loved internal medicine, and I knew that there were aspects of cardiology that I would really love, in particular the patient relationship. So when I got to my medicine rotation, I was really excited to completely dive in. But one of the primary factors that was holding me back was sort of this second guessing of whether I could do it. This imposter syndrome that we all hear a lot about, that can be kind of nagging and very insidious. This question of, did I belong? Could I do this? And those kinds of things. I was really fortunate, and one of the things I think is important for us all to think about is that I had some role models as I was going through my training. When I was a third-year student, Dr. Aiko Kosa, who is currently one of the heart failure attendings at Northwestern, he would kind of take us under his wing and teach us about cardiology and teach us about EKGs and clinical scenarios. I was inspired by our chief of cardiology, Dr. Yancey, who's also a Black man, and he had kind of risen to the ranks of national and international leadership. And I think those examples really helped. And so I think one of the things is, how can we think about building in those examples so that trainees who are younger see people who look like them in the years ahead? One of the things we did here was start a mentorship program that kind of builds that in specifically. And so it's very regimented. and we have fellows and residents who serve as mentors for students. And so it's a way that we can all see each other and kind of really converse with each other and say, hey, I can do it, no matter what the specialty is, but particularly for cardiology. But clearly, when we're thinking about diversifying the field of cardiology too, we have to invest in the deep pipeline. And that starts, in high school or even before in grade school, exposing our students, our young learners to science, exposing our young learners to people who look like us so that they can know that this is a potential field for them. And so I think, again, that mentorship and that support that came up in the discussion with Dr. Motta is really, really important.
Thank you for that. And, I think, we talk about the pipeline and the importance of mentorship, and maybe towards the end of the discussion, I think we're going to have the conversation about, well, who is actually on the other side that's screening the applications for residency and for fellowships, because I think that also has to come into play. And we can mentor people very far and get them to a point, but we also have to think about who's on that other side and doing the accepting when it comes to from the program and fellowship director level. So more to unpack there. But I want to switch to speaking specifically about cardiology and the practice itself. What are some of the upstream interventions that you've seen? As we know the disparities exist, we know that they're there. So what are upstream interventions that you've seen that are proven to be effective in addressing the equity issues related to heart health?
It's a really great question. I think upstream interventions obviously need to focus first on the identification of the disease, and then really focus on access to treatment. A lot of the things that I've seen that have been effective are initiatives that look at first this identification question. So screening for blood pressure or screening for blood sugar in high-risk neighborhoods and communities, recognizing that identifying hypertension or diabetes, for example, and helping to control some of those risk factors for further cardiovascular disease is going to be really important. Secondly, thinking about the social determinants of health and how those really drive inequities is going to be also important. I think one of the challenges when we think about what the initiatives are that are upstream is oftentimes the communities or neighborhoods that really need those specific interventions lack the resources to potentially enact those interventions. And so we need it to be a national and really an international focus for us to use the resources that we have in order to affect change. I was speaking earlier while I was on rounds, and there are maps going around, I'm sure in Boston as well, about who's vaccinated for COVID-19 and who's dying from COVID-19. And there is this disparity that has existed from the beginning of the vaccination rollout that is continuing to worsen and worsen and worsen. And so it's one of these things where it's, as you mentioned, Dr. Landry, even though we're aware of it, it's kind of almost like a runaway train. And so what are the things that we can do? And I think the first thing we need to do is recognize this an issue, but then also enact policy from day one when we recognize that, to ensure that that equity exists. And that's true for cardiovascular disease as well. The other thing that I think is important is ensuring a really strong and maximized healthcare workforce, recognizing that as physicians, we're going to do all we can to help to really make change in these communities that need it, but also that our allied healthcare professionals, whether nurse practitioners or physician's assistants, community pharmacists, community health workers, really meeting the community where they are and targeting those patients as best we can. There was a really great study looking at, a barbershop intervention for blood pressure, and where they had kind of community pharmacists that interacted with Black male patients in the barbershop. And so I think thinking outside the box about how we can really meet patients where they are and not just at the ivory towers of the institution are both going to be important.
Thank you. And that was a very public health type presentation right there. I answered that question. So I appreciate that from thinking about my public health background and meeting patients where they are and thinking about the environments, that they live in. And the importance of thinking about its the zip code versus the genetic code, which is a conversation we often hear play out in the schools of public health, but not necessarily in practice in medicine. So we definitely need to have that more of that flavor as a part of our discussion around healthcare. And then my last question to you is, as medicine continues to evolve, we're seeing new medications and new interventions that are coming into play, if not every week, every day. However, not everybody has equal access to these new interventions and medications, or if they do, they come in at extremely high cost. Can you talk about how this is a disparity that's impacting care and what we can do to address these issues related to the novel treatments and drugs that are coming into place?
Absolutely. This access to care question is really important in cardiovascular disease, particularly as you mentioned, as we become more sophisticated in the treatment strategies that we're able to offer. My clinical interest is in advanced heart failure. And so, there are these guideline-directed medical therapy that we know work. There are minimally invasive procedures like transcatheter aortic valve replacements, mitral procedures, but who has access to those? And particularly as the field is continuing to move forward, and we know that they have really profound benefits on mortality and on quality of life. This access question is really important. I think the first thing is to think about, kind of what are the components of access. And so there's acceptability, availability, appropriateness, and then affordability is probably one of the major issues. And that's one of the major drivers of healthcare disparities. I think to get at that question about affordability, I think it's going to take, again, a lot of resource reallocation to make sure that patients who need it can get the services that they need. But then this question of access even comes into play when we think about access to specialized care. So Dr. Alden at the Brigham actually did a study, I think last year, in Circulation, where he looked at patients who were admitted, recognizing that there's been a lot of data to show that patients who come in with heart failure get improved care if they're seen by a cardiologist as an inpatient. And he found, probably not surprisingly, that Black and Latinx patients were admitted to inpatient cardiology services at lower rates than white patients. And so thinking about why that is and what kind of interventions we can put in place to prevent that from happening, so that we know patients can get the best care possible. And then lastly, I'll just mention this piece about, we have so much going on with science and randomized controlled trials in cardiology, ensuring that we kind of have, again, this latest and greatest and a lot of options when we're trying to treat patients. But I think we need to also shift our focus a bit to more of the implementation side, and recognize that how can we implement these and how can we make sure that patients, for example, have their SGLT2 inhibitors for their heart failure, or their mineralocorticoid receptor antagonists, and those kinds of things. Again, coming back to the point of not only is it for patients to improve their mortality, but also quality of life, right? And so our main goal, right, as physicians is to make sure that people can live the best lives possible. And so if we continue to allow these disparities to exist and widen, then we're affecting all those things at once.
And I just want to go back quickly to the study that you mentioned. I believe that study was actually the patient population that they were looking at was at a tertiary care academic center, correct? It wasn't.
That's right.
And so where they have those cardiologists, specifically heart failure cardiologists, who could be there and those patients could end on those services, but for one reason or another, those patients were not admitted to a place where they should be receiving ideal care. I think that's interesting. And there's, understanding we're talking about heart health, but I recall seeing a very similar type of study where they looked at individuals with breast cancer and how they, Black and Latinx patients were more likely to be referred to a general surgeon as opposed to a breast cancer surgeon for treatment in California. So again, this is same song, different verse. We're seeing the disparities play out, just looking at it, different disease and seeing that we're not getting our Black and Latinx patients in front of those specialists.
Absolutely.
Thank you, Dr. Youmans. I have a couple more questions for you that we'll come back to you in a second. I do want to turn to Dr. Lopez next. Again, congratulations, Dr. Lopez, on your promotion, and thank you for joining us. I do want to say Dr. Lopez is an alum of the Commonwealth Fund Fellowship in Minority Health Policy as well. So it's always great to see fellow Reed scholars joining us for our presentations. You're a pediatric cardiologist, and so pediatric cardiology has its own unique challenges, from congenital diseases to conditions historically considered to be, not considered to be adult issues, but now becoming more and more common. And then also issues that we typically see in older patients now happening more in younger patient populations. How do we incorporate preventative cardiology into pediatric cardiology? whether it's screening for obesity, hypertension, or elevated cholesterol that lead to potential higher risks, or as well as looking at congenital heart diseases as well.
First of all, thank you so much for bringing pediatrics into this space. Oftentimes we are not discussed in when there's conversations surrounding adult cardiology, and our patients are growing up and becoming adults, and so it is a very important conversation to have. Certainly, all the problems that as we were discussing previously, that used to plague solely adults, obesity, hypertension, elevated cholesterol, and even fatty liver, those are much more prevalent now in the pediatric space. And so in the last 3 decades, obesity has actually doubled in childhood and tripled in adolescence. And that's a pretty massive number. I think there's an estimated 19% of kids between the ages of 2 to 19 are now officially classified as obese in the United States. And those prevalences of obesity become higher as one ages. But there are also certain populations who tend to be more at risk, not dissimilar from adult populations, for the same darn reasons that you see in adult populations. So systemic inequities, food insecurity, lower socioeconomic status, a lot of these issues that plague adults in communities of color will also then plague their children. And so, we're looking at rates of 26% of those that are obese, 26% are Hispanic, so they're certainly in the highest risk category, and 22% Blacks, which is the second highest risk category, compared to 14% for whites and 11% for Asians. And so certainly the disparities that we see in the adult populations trickle down to the pediatric space. And that's important because it has other implications. So if you have a lower socioeconomic status, you're more likely to be obese. You're more likely to have a hard time getting access to healthy food. You're more likely to be living in a food desert. And so you're more likely to be obese. And so if you're obese as a child, your health risks coming into adulthood are far worse. And that's particularly true if you have congenital heart disease. So congenital heart disease is the most common birth defect that exists. It's 1 in 100 births. It's over 40,000 births a year. And some of these are quite severe, some of these lesions requiring surgery in the first week of life. Some require multiple surgeries. And so you can imagine that if you have a heart lesion that requires several open heart surgeries, and then layer on top of that having obesity or high cholesterol, especially in a child who had their coronary arteries manipulated for a surgery, their outcomes can be much more significant if they are obese. Or if they have some of these high cholesterol. And so I think that's part of the reason why now the AAP has actually done universal screening that's starting at the age of 9 to 11 years old is now universal cholesterol screening for all children, given these rates of obesity, and actually anywhere between 2 to 8 years of age, if you have risk factors, including obesity, hypertension, diabetes, etc. And so it's something that is becoming much, much more prevalent. And the last thing I'll say on this topic is that we know that in congenital heart disease patients, they have a higher risk. We've done a study looking at this. They have a higher risk of having, or higher odds rather, of having anxiety and depression and ADHD. You also have higher odds of having those things if you are obese. You have a higher issue with self-esteem, different sleep issues, sleep apnea. If you're obese and you have sleep apnea, that can affect your heart as well, even in childhood. And so there are several interplaying factors here that are specific to children, but I think are more concerning if you have a congenital heart lesion.
So it seems like there's a lot of, again, upstream issues that we need to be addressing in addition to the acute medical issues that children can be born with these congenital heart diseases. Switching topics a little bit as we're still in the midst of the pandemic, and hopefully we're winding down, at least for as we transition from winter to spring. COVID-19 has been a particular concern for pediatrics. How has the pandemic impacted your work and care for patients with heart disease and just pediatric patients in general?
It's fascinating to see the evolution of COVID-19 and see what people used to think and what we now know as the science has revealed several layers of things as time has gone on. So it used to be, when it was more prevalent in Asia and in Europe before it really kind of took off in the United States, it was thought to be an old a geriatric disease that mostly affected men. And then as more and more data came out, that was found not to be true. And then as more and more data came out in the United States, and they found these racial and ethnic disparities in adults, lo and behold, they actually started looking at those data in children, and sure enough, there were racial and ethnic disparities in children as well, not just for acquiring COVID, but also for being hospitalized from COVID, but also from dying from COVID. And additionally, the entity known as MISC, multi-system inflammatory syndrome in children, was an entity that became that was described in April and May between the UK and the US. And this entity is something that is an antibody response to COVID, where if you have COVID, you may be asymptomatic as a child. Children tend to be less affected, generally speaking. But this particular entity, your antibodies are formed because you had COVID, and now your body starts attacking those antibodies. So you have a multi-system inflammatory response, not dissimilar from what we see in Kawasaki disease. So we thought, oh no, who's getting affected by this? And sure enough, the rates of MISC are higher in racial and ethnic minorities, just like it is for acquiring COVID. And so there's a lot of stuff that we're seeing in pediatric cardiology, even in patients who don't have congenital heart disease, that now we're having to do screening echocardiograms for all athletes. So if you want to play sports, we have to now screen you with an echo, because you can be asymptomatic with COVID and have a cardiac scarring or arrhythmias as a result, even if you didn't have any symptoms when you had COVID, or even if you never had MISC. So we are now doing much more screening, not only of cardiac function, not only of cardiac relaxation, but also of coronary arteries, which we are finding sometimes are affected, even if you don't have MISC or a multi-system inflammatory response, but if you just had COVID and you were asymptomatic. So it has impacted us significantly in that now we are doing much, much more screening in patients who don't even have congenital heart disease, but who require seeing a cardiologist for clearance and requiring an echocardiogram and potential treatment for some of the effects of COVID.
And you're down in Texas, where there's a huge sports culture, and especially at the high school level, and even younger. And I can see that this is potentially going to be an equity issue and an access issue as you think about those younger individuals, whether it's in inner city Houston or rural Texas, that are looking to get clearance. And how does that all play out? And how do we make sure that a lot of these pediatric patient populations have equitable access to the folks like you in order to do those screenings? So a lot to unpack there. Maybe we could talk about that a little bit more afterwards. Can you lastly talk about some of the issues related to congenital heart diseases, and what happens to those pediatric populations when they grow up, and where do we see those individuals and sort of this continuity of care as we look at them transitioning from pediatrics to adolescence onto early adulthood?
Well, it used to be in pediatric cardiology that our goal was to have patients survive. So that was our unique goal, and that was it. And so we thought we were pretty great once they started surviving, especially for these really critically congenital heart lesions like hypoplastic left heart syndrome, transposition of the great arteries, anything that requires unique surgeries or a series of surgeries to fix the patient. And so then we said, oh, they're surviving now. Yay, they're surviving. This is great. And then we started noticing that there were some other issues that were associated with this patient population. So learning disabilities were more prevalent with this patient population. So we started doing neurodevelopmental screening because, when your brain sees purple blood instead of red blood in utero, and for years thereafter, it can sometimes change some of your risks for having learning disabilities, or even having open heart surgery multiple times for that matter. Anxiety, depression, and ADHD. These are things that we are seeing that are much more prevalent than we previously thought. And like I said, we recently published a paper on this, and we found that children as young as 4 can exhibit anxiety and depression as a result of having had congenital heart disease, and that gets carried on into adulthood. And so some of these issues that you had as a kid kind of move into adulthood. And the real issue in the adult congenital space is that entity, adult congenital heart disease, it requires someone who understands pediatric cardiology to then take care of adults with pediatric issues that are now older. And so adult cardiologists actually get very little training in congenital heart disease. As a matter of fact, the requirement for that training is 0. You are actually not required to have any training in congenital heart disease as an adult cardiologist. There's a suggestion of having lectures, there's a suggestion of having rotations, but it's not required. So you can go through your whole adult cardiology fellowship and never see a patient with congenital heart disease, and suddenly an adult with half of a heart walks into your clinic, and you're just not equipped to take care of this patient. And so when you look at disparities in care, maintaining insurance is an issue for this population, because educational issues and then getting jobs can be an issue for this population. But furthermore, who they see ends up being a real disparity. So as of 2015 was the first time that board certification was offered in adult congenital heart disease. And as of 2015, there are in America 550 adult congenital heart disease board certified specialists, 550 for America. And so that means for every one adult congenital specialist, there are at least 4,500 patients that have congenital heart disease. So you can imagine most of those are concentrated in large centers, which are concentrated in big cities. And so access is an issue if you're in a rural community. Access is certainly an issue if you have insurance problems. Even under the Affordable Care Act, we just published a study on disparities in congenital heart disease under the Affordable Care Act. And even then, there are disparities in the transition age period when people tend to lose their insurance between 18 and 25. And even if you have Affordable Care Act insurance, because not all places accept that. Not all congenital heart disease centers accept that type of insurance. And so we have a huge math problem now for our hugely quickly growing adult congenital population, and who is going to take care of them, and how are they going to be taken care of? Because as we talked about, the adult issues that plague people that don't have structural heart disease plague these individuals as well. And furthermore, they also have other related organs that can be impacted because of their congenital heart disease, like their liver, thyroid, etc. And so it's a big math problem that we're dealing with now. I will say one other thing that's fascinating as I've been listening to the other discussions in pediatrics, 72% of the pediatric field is women. It's a heavily female populated subspecialty or specialty. In pediatric cardiology, because there's so many women that are in pediatrics, the discrepancy between women and men in pediatric cardiology used to be much more, but actually now you have 50% of all fellows in pediatric cardiology are women. And so that's quite different than in adult cardiology as well. We have other issues in terms of racial and ethnic diversity in our trainees, but from a gender perspective, it actually looks somewhat different than it does in adult cardiology.
That's interesting, and I wonder how that's going to play out as there's more parity when it comes to gender identity in medical schools, as we're now seeing more classes that are more women than men starting in the past few years, and see what's going to happen to the future of our specialties and subspecialties. And I want to just say thank you for really unpacking the layers that are associated with these issues, whether it's the obesity and the socioeconomic issues, as well as the overall prevalence of congenital heart disease, and then how that layers with the mental health issues that comes on top, which can result in education and achievement gap issues, which can lead on to thinking about employment and insurance, and then thinking about rural versus urban and access to care. And I think it just really helps us to see that, all of this is something that we think about in, big terms of, large academic centers. The reality is there are people in small town America who are going to be suffering, and they're not going to have access to care for a number of reasons. So thank you for really helping us to think about those issues specifically related to congenital heart diseases. I want to say this to the audience. We have the Q&A session open. So if you have questions, start to fill those in. We have one more panelist, and after Dr. Johnson speaks, I want to try and go through some of the questions that the audience may have, in addition to a few questions that I have for the prior panelists. So Dr. Johnson, again, thank you for joining us. And Dr. Johnson is also a Commonwealth Fund Fellow alum. And thank you for being here and part of this discussion. I want to talk to you more from a leadership perspective. And can you share some of insights related to equity issues that you're seeing from leadership in the decisions that a division and a hospital may make that may actually have an impact on patient care that we aren't necessarily thinking about because we're thinking about it from a public health perspective?
Well, thanks for the introduction and congrats on a wonderful program. You know, if you'd asked me this question a year ago, my answer would be, you know, very different. So 12 months ago, the things that were on my radar included, you know, as an academic center, are we seen as approachable to, you know, brown and black patients? What are we accessible to Black and Latinx patients who have to travel a significant distance to come to our outlying sites? Transitions of care when we are moving patients in and out of our specialty hospitals, you know, are we providing patient navigators? Do we have enough support for multiple languages, things of that sort? And then came COVID-19, which really, as has been said already on this call, brought everything to a head and has evoked the need for us to look at all of our public health principles and to see those things brought to very granular detail at the leadership level, to me has been very rewarding and very reassuring to see how people have adapted and how leaders have had to be moved by the data and respond to the need. So in the beginning, when we were on, you know, institutions went on lockdown and people who could work remotely looked to work remotely. But, you know, as we know, many people don't have that luxury in our frontline staff and people who are providing care to patients and also making a hospital run had to, in New York City, had to take subways, people can't drive to work. And these are the people where we saw we had the most incidents of disease or COVID-19. These are people who were admitted more frequently. And it was our support staff more than our direct clinical providers. And so when the vaccine came out, you know, we had lots of data showing us who in our own staff was at highest risk of developing COVID and where it is that people really had been ravaged. And I'm happy to say that institutions rose to that challenge and said they were going to selectively vaccinate those populations first. And I think that was an example of health equity at work. And I think that COVID really brought this home, a way in which in other situations you bring these things to the fore and they seem somewhat more abstract. But I think COVID really brought it home and was just, it was so miserable and painful that it was inescapable. And then when it was time to roll out vaccines to patients, the questions again arise about what's the equitable way of distributing vaccine. You know, there are state mandates and there are CDC recommendations and there are individual organizations that make recommendations, but each hospital or each organization is aware of its own data. And so trying to respond to that data in what is a medical legal climate, in a way in which people feel heard and know that they're not left behind, you know, responding with messages on the portal, but then who are we leaving behind if we're relying on portal, and how are we going to reach out to the vaccine hesitant? You know, vaccines have to be kept, the majority of vaccines that we have availability to now still have to be kept at -40 or, you know, whatever those requirements are. Made it very easy to say, all right, well, come to the ivory tower to be vaccinated. But everybody on this call who has public health training knows that you have to meet people where they are. And so creating opportunities to be able to bring vaccines into the communities for the people who have been most impacted and continue to be most impacted adversely, who don't have homes to retreat to social distance. You know, leadership's response to those types of needs has been really something to behold. And I would like to believe that this type of momentum is something that will play out in other areas once we have, you know, once we're ahead of COVID.
Thank you. And I think it's really important for us to think, if we don't take care of our staff, then how can we take care of our communities? Because our communities are our staff, and they're, after they leave us and leave our ivory towers, they're going home, and, they're going back into their neighborhoods. And, we have to make sure that we have that level of trust and support. And we think about equity for not just our patients, but also our staff that are working for us and working with us. I want to switch topics because I saw this question pop up in the Q&A, and it's very similar to what I was going to ask you about anyways. One of the things that we do in academic medicine is we think about research, and everything has to be, sort of grounded in the data. But how do we ensure that research is inclusive of diverse patient populations? And how do we hold the research and researchers to a higher standard when it comes to inclusion?
So leadership certainly has a role to play here, but in 2021, I think it's very hard for scientists to make an argument that we should be extrapolating from one body of one population, and extrapolating from what is generally a white male standard just does not cut the mustard anymore. So I think in terms of scientific integrity, if you're making an argument to scientists, it is very hard for them to hold that ground. The more and more data that we have looking at genomics, the more and more examples that come of misdiagnosis or missed opportunities for therapeutic interventions because of using white reference standards makes it very clear the need for diverse populations in research. And the need for diverse scientists conducting research to ask these questions. The population of people conducting research is going to increase the likelihood of you being able to recruit a diverse patient population to engage in clinical trials. And as has already been said, pipeline development, leaders identifying this as being essential and quite frankly, a moral imperative is a message that I think has to come from the top of organizations. The institutions like NIH, CDC, holding investigators responsible and accountable for lack of diversity in trials, including diversity and representation and their scoring systems for grant approval, for example. Putting out RFAs that target populations that are disproportionately impacted by certain disease entities. These are ways of supporting research in this area.
And I think there's a lot of great points that you said there that we'll need to unpack a little bit more, because it's not just about doing research on the patient populations to make sure that there's diversity there, but also looking at who's even doing the studies, who's funding the grants, how the grants are getting funded, because it has to be an all-in approach when we talk about equity and inclusion, and not just a one-time intervention of getting more patients involved in the studies. So thank you for opening up the door for that discussion. And then my last question to you, again on this leadership trail, is as from a leadership perspective, what interventions are needed to increase the number of UIMs, specifically cardiologists, who go on to take on leadership roles within their institutions or just leadership roles across the country in healthcare?
Well, some of them have already been said by my colleagues, but certainly bear repeating. So pipeline development, and you can't start too early. We have to get youngsters interested in STEM. We have to get them from, no time is too soon. Programs like Commonwealth Fund program, which many of us have been involved with, where you take physicians and train them in leadership, public health policy, and nurture them and develop them such that they are ready and able to step into those shoes when those opportunities, or seize those opportunities when they make themselves available. The need for mentors, as has been said repeatedly on this call, and remains a dire need for URM in science. all along our experience, both in training, as in young career and mid-career, and I would say even senior career. Everybody needs mentors, everybody needs sponsors. And this has to come from leadership at institutions. You know, there was a study, I'm sure people have heard of this, 2 years ago, where they interviewed program directors in cardiology, program directors, and about a third of them weren't sure whether diversity really mattered. You know, that's a problem, because to the point that you raised earlier, if the people who are looking at the applicant pool do not see this as one of the top 3 priorities, then you're not going to recruit and you're not going to develop a diverse workforce. So things GME could require program directors to take training on importance of diversity. You know, there are real tangible things that can be done on institutional level, and hospital leadership needs to send a message to faculty across the institutions that this matters, and support that with supporting programs, grant support for URM faculty. The gender inequities have also been spoken of earlier in this call, but you know, the same things that adversely impact women in this field also have a negative impact on URM, and supportive environments and making sure that people do have mentorship and guidance all along the way will be crucial to having us have better representation. And I think it's like 6 or 7% and at best 11% of cardiologists who describe themselves or identify as underrepresented in medicine.
Yeah, it's interesting as you think about that study. I remember seeing that not too long ago, and then there was also some other issues in cardiology that happened with a big report that came out, or a big article that came out that received a lot of pushback from cardiology in discussing the importance of equity. It referenced affirmative action and a number of other issues that came out.
It's clear that we still see a disproportionate number of minority patients. It's clear that minority patients respond more positively in terms of taking advice and taking medication recommendations from people who look like them. So yes, without giving more airtime to a study which I've had great problems with, I agree that that is not the direction we need to move in.
Great. So I want to open my questions again to the audience, and I'll go through and try and take some questions from you all. But I do have a question for you, Dr. Youmans, and it's more of a clinical slanted question. You know, as an ED doc, one of the things that I saw in the evolution of emergency medicine is a lot of algorithmic medicine. So there's door to EKG times. We try and make sure that patients, as soon as they present to the ED, they get certain standard treatments to make sure we're not missing things. But then also we're doing a lot of work in using scoring systems to provide care for patients, and using the heart score and MACE scores and all these other calculators to figure out who needs to be hospitalized and who doesn't. How are these studies impacting health equity, and are they helping to close the gap, or are they worsening the gap? And then maybe just taking that a little bit before the implementation, were these studies actually looked at with diverse patient populations to ensure that they were going to be equitable?
It's a really great and important question, particularly as these scores become ubiquitous. I think that, you know, the first thing is to think about who was involved in these studies. And I'd have to look back at all of the studies, but I would imagine that there was likely an underrepresentation of, you know, racial and ethnic diversity within the studies. And so I think that, you know, anytime we are implementing something, we want to look at the source and see, you know, who was included, was there a diverse population, and therefore can we generalize that to all the patients that we see, for example, in the emergency department. So I think that's the first step, and I would venture to say that likely there was underrepresentation of underrepresented minority patients. But then more generally, I think that these types of approaches that are more algorithmic can actually help as long as there is representation in the studies. And the reason that is because, as we all know, we all carry implicit biases that might make us approach certain patient populations differently. Dr. Motta, mentioned for women, if we might say that there is anxiety when the patient actually has cardiovascular disease, for example. Or for Black men, for example, you might be less inclined to believe that they're actually in pain, with a lot of these studies that show that we tend to underappreciate pain in Black patients, for example. And so if we can ensure equity in these processes that are more algorithmic, it may actually help us to potentially decrease bias. But again, it starts with the studies. And again, it starts with the fact that we have to have sort of a diverse patient population that's studied within it.
Wonderful. Thank you for that. I want to turn to you, Dr. Motta, because I have a question. I know you already addressed part of this in the Q&A session, but I want to just bring it to the forefront for the rest of the audience. You're someone who works with trainees, and we often have medical students who are in these situations where they're taking care of patients as part of a team, and they are Latinx, they're Black, they're members of sexual and gender minority groups, or they just recognize that there are disparities that are coming into play with patients and how the patients are being treated. How do we empower students and trainees to speak up and address these issues? And then also, how do we make sure that the students are supported when they do call out what they see are obvious inequities in care?
I think education, I don't think, even when I was in residency or training, I don't think we have that much education. I think this is a great forum, and I think what you're doing is great because we don't explore those areas as far as diversity in, as far as gender, as far as a minority, and a lot of times we're afraid to speak up for our patients, even as especially as a medical student or as a trainee, because you're afraid of retaliation. What is my attending going to say if I go and report them? But one thing that and that's what I answer is we have to advocate for our patients. They actually are not going to be able to advocate, especially, and as a minority, I speak for myself that I don't, you tend to see regard the doctor, the physician, as an authority figure. And so you're not probably going to say anything. A lot of the times they're just very respectful. And even if they're mistreated, they under recognize and they're labeled as something and they're not, they're not going to report the physician. And I think we have to actually stand up for them and stand up for the patients and, and not to be afraid. I think we need to look for somebody that's you trust, as an attending. There has to be somebody you're able to share this information. That I don't think that you have to go openly and address it with a person that's actually mistreating the patient or given a different kind of treatment that provides for his other patients that are not minority or a certain gender. But I think talking to somebody that they trust and they're able to tell them what's going on so that they actually can go ahead and address it, report it. But it's very important to speak up. It's why I just had a medical student that he just told me that his orthopedic surgeon, that he made him a remark about one of the other medical students that are they hot, and that's just, and he told me, should I report? I'm like, yeah, that's, you don't want that person to be treating other female future physicians. And if they want to do ortho to run away because, they had a bad experience with that person. So I think my thing is they have to approach somebody and they have to be able to stand up for what is right for the patient, but always go to somebody that you're able to trust, especially in your school, and it can be maybe an upper level, it can be a resident, it can be a attending, and they'll be able to provide you more. It's hard to pinpoint somebody just because it's different in every single school or a different program that some people might be more supportive than others.
Great, thank you for that. And I think it's really just important to double down on the need for systems that are in place to support students in this, so that they don't feel like they're going out on a limb and potentially putting themselves at risk. But then also helping students to understand and trainees to understand your responsibility is to the patient and making sure that they receive the appropriate level of care. And if you feel something is not right, then you need to speak up in order to make sure that that patient receives adequate care when they're in the hospital. So thank you for that. I have a question for you, Dr. Lopez. And this is an interesting discussion. We're seeing a ton of conversations that are happening now, partially related to COVID, but then also related to this Black Lives Matter movement that we're seeing across the country, and recognizing the injustices that are happening across the country when it comes to white supremacy. And we're seeing a ton of papers that are coming out. And hopefully we're going to see this translate over to some benefits to the community and ultimately towards health equity. But how do we ensure that this isn't just a fleeting moment in medicine, and then we go back to the status quo in a number of years?
That's an excellent question. I think there's several layers to this question. A lot of this awareness and how we're going to deal with the inequities that people suddenly have been awakened to, if you will, even though they've been present for a very long time, is going to require policies. There are going to have to be policies, health policies that are put into place that change how people are taught, that change how people conduct research, that change the way that we think about the way that patients are treated, the way that we make assumptions about patients. For example, if they don't take their medication, oh, it's their fault, or they are lazy, or whatever it is, when in actuality it's an access issue. So there have to be policies in place that allow for structural inequities to be addressed to some degree, or to any degree for that matter, for some of these things to change. Beyond that, there's some other things that are at the more institutional level. I mean, that's at a more federal and even state level policy hierarchy. At the institutional level, their leadership matters. And so depending on who is in leadership, some of the priorities of that institution will change, and the way that the research is set up, the considerations that are made for task force initiatives or for diversity, equity, and inclusion, that then trickles down to how we interact with the communities, how we interact with the populations of color. All of those things kind of intersect to say this isn't just a blip and people care right now because it's cool to care about disparities suddenly, and then it goes away. So it requires a constant reminder. It requires ongoing data. And I think I saw a question here in the chat as well. How do we just not make this yet another paper in research about, hey, did you know that there's disparities that happened like 15 years ago when I had this data? I mean, that's also important. So coming up with quality improvement initiatives, coming up with interventions. I'm also tired of papers that only describe the problem and that don't have policy recommendations or don't have interventions that might change this, because it's a systems issue. And so it requires a systems approach to fix it. It cannot just be done by one person alone. That being said, if you have people at the leadership level that have a similar vision of diversity, equity, inclusion, and belonging, that will help in terms of how patients are treated, what research is conducted, what are the priorities of the institution, etc. And the last thing I'll say is, we've talked a lot today about mentorship. Mentorship is great, but there's a statement that I heard that I think is very accurate, that women and minorities are mentored to death. What they are not is sponsored. And there is a very big difference between being sponsored and being mentored in terms of how far you go, in terms of promotion, in terms of leadership positions, in terms of people going to bat for you to be the head of a committee or to run a certain program, or et cetera, et cetera. I mean, a lot of these opportunities don't happen through mentorship alone. They require sponsorship. They're requiring someone to actually put you forward and say, I think this person matters. I'm going to bring them up and bringing up individuals from someone that's in a position of power, some sort of a leader in the institution, to bring someone up and bring them into the leadership circle so that there is some representation. And so that also matters a lot in terms of how are we going to have more people on editorial boards, on medical student admissions committees, on, you name it. It's going to require not just mentorship, but it's also going to require sponsorship and advocacy.
I 100% agree with that. I think we can talk more for hours about minorities and women being over mentored and under sponsored. I think that's a key discussion that we can build out later. And I just want to go back to what you were saying earlier. There have been lots of times when medicine has said, "Oh no, there's not a disparity," and then we find the disparity and say, "Oh look, there is a disparity, but it's probably not meaningful." And then we say, "Oh, there is a disparity and it may be meaningful," but there's never any discussion around, well, these are the solutions to addressing the disparity, and this is the funding that we're going to put in place so that we end the disparity.
And that's a policy issue.
Yeah, and that's the direction we need to be moving in. It's not just identifying. We're great at pointing out the lesion. How do we fix the lesion? How do we prevent the lesion from even happening? And that takes a change in mindset for us. And I don't know if medicine's ready to grapple with that. And to be honest with you, it goes beyond the hospitals and goes beyond the research lab. So there's lots to discuss there. I want to turn to you, Dr. Johnson. This was another question from the audience. We have these amazing institutions. You're at an amazing institution in New York, and we often consider them ivory towers, often forgetting around the populations that are around them, or never even opening our doors to those populations when they want access to the resources that we have. And so how do these institutions go back and build better relationships with the community and also validate the suffering and the neglect that we've potentially shown towards our patients in the past?
It requires concerted effort at the part of hospital leadership, as has been said, community engagement, working with identified leaders within the community to find out what community sees as their needs. Again, Public Health 101, not coming in with solutions that come from the ivory tower, and really forming what will be long-lasting relationships and addressing things that matter to the community, social determinants of health, So it could be, is it that you need to have a presence in offering high school students paid summer internships to show that you really are committed to building out STEM in the community? Is it that, I'm worried about your taking your medication for your hypertension, but I'm not mindful of the fact that, you have to travel an hour to come see me just to get your blood pressure checked, So really understanding that these are a two-way street, and meeting a community where it is, and removing some of the barriers to entry and being more accessible, seeing more people who look like our communities on staff, nurses, physicians, and physician leadership. I think those are some of the efforts that have to be made, and as was raised in one of the Q&As, it can't be another situation where people go into the community to do research and then run out once a paper is written. It's really, we can't still be doing that in 2021.
Agreed. And I think that it's not just about doing the research in the communities, but engaging the communities so that they benefit from the data that comes out of the research, which unfortunately hasn't been what happened.
You have to help drive the research questions, and drive how the research is conducted and how the team looks like.
Exactly. Well, I want to say thank you to our panelists. I want to say thank you to Dr. Michelle Johnson, Dr. Keila Lopez, Dr. Angelica Motta, and Dr. Quentin Youmans for joining us. You be sure to visit the DICP website for more information about our events. Thank you for joining us on this evening, and we wish you nothing but the best during the rest of this Heart Health Month, and continue to stay safe, practice your physical distancing, wear your mask, and get your vaccine, and be an advocate for your communities as we move forward. So thank you for all joining us. Thank you to Dr. Reed. Thank you to Jasmine Stecker for helping to organize this panel. And then again to our panelists for joining us, and everyone have a good evening.